So who is answering today?
Good evening, sir. I am Abhishek. Sir, I'll be answering today, sir.
Okay. Ojas is answering.
Hello, good evening, sir.
Prashant, you are answering today?
Yes, sir. Both of us are answering.
Okay.
Abhishek and myself.
Okay. So he has not joined yet, Paras.
I'll call him, sir.
And I'll call Dr. Gite also.
Yes, sir. पारस कब लॉगिन कर रहे हैं? लॉगिन कब कर रहे हैं?
So we will start in 5 minutes, 5 to 6 minutes. Okay?
Okay, sir.
Paras, Dr. Hiren is still operating or he has finished?
Sir, case is over, sir.
Okay. So I think he will go home and then join.
यूसुफ सैफी सर केस
Yusuf Kesefi,
उनका केस चल रहा है सर.
Hiren is free now, na?
हाँ हिरेन सर.
Okay. Okay. So, Dr. Gite and Pankaj, today we will do two cases. One is a long case and one a short case. You have got both the case, na, Paras?
हाँ yes.
So that is why I want Hiren and Pankaj both, because it is their expertise. One good news, our beloved Professor Dr. Gite is now council member in West Zone. So it's a great thing. We'll have a good support and he is working very hard. So a request to all of you that if you know any one of your senior colleague who has passed his exam, and if he is not member of USI and West Zone, just let us know. We'll send them form, especially Dr. Gite. He is looking after new membership. So I request all of you, and also when you pass your exams, please become a USI member and immediately West Zone member.
So I thank you everybody who has supported me directly or indirectly for winning the council membership, and I am always there for all the students throughout the year, probably whatever time I have possible for that.
I think we should also congratulate Dr. Gaurang Shah. He now becomes the secretary.
Yeah, thank you. And yeah, so Pankaj, my idea is just like us now. Why can't we start a students' corner? Like in the like we are moderator and there are participants and we ask them question. I'm thinking that let there be a small corner for them also. So one of the session we can have where only students are there. The moderator are also students and the answering candidates are also students. What do you think? How is the idea? So that we are training them. Basically, we train them and they are very well read. So we will come to know, what is going on in their mind, how they will start their practice, where are the fallacies.
That's a very good idea, Doctor. But I feel that there still should be somebody as a moderator. Maybe the moderator could just talk at the end.
Okay. Yeah. So at the end,
there the first 50 minutes be managed by them, and in the last 10 minutes, say Professor Gite or somebody just gives a final comment. That will be better, I believe.
Yeah. No, this I am thinking even in conferences, we give them some corner, one corner. And where, as you are saying very rightly, 10 minutes, it will be a senior consultant or someone who is expert in that. He will give his opinion, whether whatever they have discussed, is perfect or there is any, there should be any change or any difference of opinion.
Absolutely.
So that way we are training them, So
True.
once they become consultant, they know how to appear in this thing, conferences and how to conduct this session.
Well, I think Hiren has also joined.
Yeah, I think then we should start now.
And I think Dr. Khuddedar is also there in the meeting.
So we can unmute Dr. Hudeda. So the thing is that today, Pankaj, you and Hiren and Hudeda, you mainly take over because these two cases are very good cases and very good discussion. You can do it.
Sure.
Right. So Paras, you are ready?
Yes, sir.
Okay, start. So today, three people or two people are answering.
Two, sir. Prashant
Okay.
sir and Abhishek sir.
Okay, fine.
So presenting a case of a 50-year-old gentleman shopkeeper resident of Mumbai, presented with on and off right flank pain since 6 months. Hello.
Yeah, Prashant or Abhishek, please start.
Yes, sir. Sir, I will like to elaborate about the chief complaint, the origin, duration of and progression of the flank pain, nature of the flank pain, whether it is dull aching or colicky, and whether it is progressed or not, whether it is radiating or not, whether it is associated with nausea, vomiting, hematuria, whether it is associated with LUTs, and during 6 months has he taken any medication, and whether there is any improvement or not, and also like to ask about whether there is any aggravating or relieving factor for the same. And I also like to ask about other negative history, sir, like hematuria, uh, previous episodes of pain in abdomen, history of lithuria, and history of weight loss, anorexia. I would like to ask about, and history of lower urinary tract symptoms. All these things I would like to ask.
Okay, Ojas has also volunteered. So Ojas is also there. So Ojas, you want to add on anything? Abhishek?
Yes, sir. Sir, to elaborate on the pain, sir, the onset,
No,
duration, and progress, nature,
no.
severity.
Don't
Yes,
repeat.
sir. Okay,
Abhishek,
okay,
don't repeat.
okay,
Just tell us
okay.
anything extra.
Sir, I think everything has been covered, sir.
Okay, fine. Paras, go ahead.
Yes, sir. So, according to patient, he was asymptomatic 6 months back when he developed right flank pain, sudden in onset, progressive colicky in nature, associated with nausea and vomiting, non-radiating, non-referring, and was relieved by medication. These were in episodes. Last episode occurred 7 days back, for which patient consulted to our OPD. There is no history of trauma, fever, dysuria, no history of lower urinary tract symptom, lithuria or hematuria. There is no history of facial puffiness, pedal edema, or breathlessness. And past history, patient is known hypertensive and is on medication. No other comorbidities. Patient has history of right pyelolithotomy 10 years back. No records of that surgery were available. Personal history, patient is mixed by diet, no allergy to any food or drug. Sleep is normal and undisturbed. Bladder bowel habits are normal. No addiction to any form of tobacco or alcohol intake. Family history is nothing complicated.
Yes. So whenever you are suspecting any stone disease, or at that time in a negative history, you should add one line, that is no history suggests of chronic renal failure. That is one thing. Another thing, examiner may ask you what is the importance of trauma. Why you ask the history of trauma? So can anybody tell why he had asked history of trauma?
Sir, past trauma may lead to, sir, traumatic PUJ obstruction leading to secondary stones, sir.
Sir, it can be
in a normal kidney, if suppose there is a small amount of blow in the renal angle or some injuries, so it usually doesn't have pain. रहा भी तो इतना 6 महीने नहीं रहेंगे. So when until and otherwise kidney is pathological, and in that pathological kidney, if someone has a trivial trauma, then that may end up into some major problem, like patient have large cyst,
Huge.
patient have anomalous kidney, obstructed kidney, polycystic kidney, or obstruction may be due to anything. Palpable lump है और उसको इंजुरी अगर हो गई तो that will end up into major trauma. So that is
Right.
the importance of history of trauma.
And Abhishek,
And
my suggestion is, sorry, Dr. Gite, go ahead.
History of family history, in family history also, if I am examiner, why you are asking family history, in which disease you are interested in family? Suppose 50-year-old male presented with trauma. So one of the diagnoses in your mind is obstructed kidney. Obstructed kidney may be due to
PUJ.
anything. It may be due to
PUJ.
stone, it may be due to PUJ, it may be due to stricture, it may be due to anything. Malignancy भी रह सकता है. 50-year-old है और 6 months से पेन है. तो what are the familial things you are interested in? तो ये चीज हम हर बार डिस्कस करते हैं. तो ये अर्ली फेज में गाड़ी रुकना ही नहीं. जैसा मेटाबॉलिक कॉज है तो पेडियाट्रिक में मेटाबॉलिक स्टोन्स डिसीज कॉमन रहता है. हाइपरयूरेसिमिया है, स्टोन टेंडेंसी रन इन फैमिली, तो व्हाट टाइप ऑफ स्टोन्स रन इन फैमिली, ये सब चीजें टिप ऑफ टंग पे रहना चाहिए. ठीक है.
Okay. So, Prashant, what next?
Sir, past personal family history, I would like to, and then I will proceed for the general examination, sir.
Okay, Paras, go ahead.
So in general examination, it's grossly normal. In upper abdomen examination, there is only grade 1 prostate enlargement. Rest is normal. And there is a scar mark on the right healed scar mark in the right flank region.
Fine. Ojas, you want to ask anything else or you want to go ahead? Ojas or Abhishek?
Yes, sir. Sir, the scar mark, sir, I would want to examine, sir. If there is any associated hernia or anything, sir, else I'll proceed, sir.
Okay.
There is no sign of any herniation. It's a healed scar, healed healthy scar.
Okay.
Before you proceed, what are your differential diagnoses at this time?
Sir, 50-year-old male patient with frank pain since last 6 months, and also a history of right-sided pyelolithotomy. Sir, my first differential diagnosis will be, sir, stone disease, right renal stone. And second will be, sir, PUJ obstruction. Third will be any ureteric stricture or and fourth will be, sir, any mass arising from the right kidney.
Why did you say ureteric stricture?
Sir, because patient is already operated for pyelolithotomy, it might be.
So why should pyelolithotomy cause ureteric stricture?
Sir, not
देखो,
ureteric. Yes, sir.
While telling the diagnosis, you think twice.
Yes.
One first you are telling stone disease. That is okay because patient may have recurrence. That is perfectly fitting. Then you told PUJ. That until and otherwise patient had a PUJ due to some stone, again recurrent stone. Then how can PUJ will be the diagnosis? The primary person who has done a stone operation, that is by open method. So he may have treated if this patient had a PUJ also. Until and otherwise post-operatively he developed a secondary PUJ due to his surgery or newly
Yes.
formed stone.
Yes.
Then only it is possible. So second diagnosis cannot be PUJ.
Yes.
It can be cyst. It can
Yes,
be simple cyst. It can be complex cyst. There may be infection inside the cyst. There may be bleeding inside the cyst. So cyst may be compressing to the pelvic callus, cysting and causing operation. So cystic disease will be the second diagnosis.
Yes, and probably even I would put say tumor or malignancy above PUJ or stricture.
Agreed, sir. Agreed, sir.
Okay.
Fair. So with your diagnosis of suspicion of urolithiasis, how would you start investigating?
Sir, first I would like to do urine routine and urine culture of this patient, and then serum phosphate, serum uric acid, and serum calcium.
मेरे
And
भाई
I'll also
phosphate से क्यों शुरू कर रहे हो?
serum calcium and uric acid.
And why do you directly want culture?
So itna classes लेने के बाद में this such type of mistakes should not be there. So whenever patient came to you in your OPD and your diagnosis is suppose initially stone disease and another is suppose for example cystic disease, do you do a urine culture? Does this patient had a fever? Any lower urinary tract symptoms? But why directly urine culture without knowing the urine routine report? Until an other urine routine report suggests there is a abnormal number of the pus cells, then only you have to go for the urine culture. Our patient may have clinically signs and symptoms of sepsis. Then only both can be given at a single time. So this type of mistakes cannot be allowed inside the exam.
क्या होगा? Your discussion can completely go on culture.
Yes.
And if the examiner starts discussing culture with you, you are in deep trouble. Understand that.
Agreed, sir.
Okay. So, and like phosphate was, I'm sure, was a slip of tongue, but don't say such things. Chaliye. So let's begin again. Urine routine. What else do you want?
Sir, urine routine, serum calcium, and
Again, why do you want calcium, sir?
So do you do
done for metabolic evaluation? Have you diagnosed stone yet?
No.
So why are you doing metabolic evaluation?
Agreed. Agreed.
So the first set of investigations will be to make a diagnosis.
Go slow and systematic, na Prashant. Just think about it. When patient comes to OPD, what do you ask for? CBC, urine routine, sonography,
Creatinine.
Ultrasound.
creatinine. Why you are not asking these simple 4 questions? Don't get nervous and don't talk only about stone disease. Why you want?
Tell whatever you are doing in your center, in your OPD, day-to-day basis. Don't tell any theory in practical.
Yes.
So suppose तुम करते हो का सीरम कैल्शियम पेशेंट आए बराबर कौन सा भी पेशेंट है क्या इंडिकेशन है सीरम कैल्शियम का तुमको डायग्नोसिस ही मालूम नहीं है ना.
Yes, sir.
Okay.
So let's revise again. So we will ask for a CBC, urine routine, creatinine, and an ultrasonography.
Ultrasonography. Yes, sir.
Do you agree with this, or you want anything more than this?
No, sir.
No, sir. Okay. So give these reports, please.
On urine routine microscopy, the pH is 6.5. Sugar protein are absent. RBCs are 6 to 8 per high power field. WBC is 7 to 8 per high power field. Epithelial cells are absent. Hemoglobin is 11.3. Creatinine is 1.12. Uric acid is 6.14. Potassium is 4.4.
So we confirm that urine routine is normal. CBC doesn't show raised total count, and urine routine has not shown significant anything, but maybe mild microscopic hematopyuria.
Yes.
Okay. So does it fit in your diagnosis? Where has your diagnosis moved now?
Yes, sir.
It fits in. So now what do you want next?
Sir, ultrasound of kidney, ureter, and bladder.
बताइए sir, ultrasound.
Yes. So Ultrasound was not done. X-ray KUB was done.
Okay, चलिए. ठीक है. Please read this X-ray.
This is sir ultrasound of the abdomen and pelvis along with sir ultrasound of sir
X-ray.
kidney ureter and but sir pelvic area is not properly taken in the X-ray.
Prashant, you are saying ultrasonography. This is plain X-ray.
Sorry, sir. This is X-ray of plain X-ray of kidney ureter, but sir pelvic area is not properly exposed, sir. Not properly seen. The bony, it is well exposed and preparation is adequate, sir. Bony markings are normal, sir, and there is radio opaque shadow seen in the region of right kidney on right side, sir, and there is also one radio opaque shadow on the left side in the lower ureter. Right radio opaque shadow suggestive of complete STAGHORN calculus.
What is the size of this right radio opaque shadow?
It is around, sir, 8 to 9 centimeters.
And how did you calculate that?
Sir, with the length of the vertebral body, sir.
Perfect. So you see in the right renal area radio opaque density, which is taking the shape of the pelvic elevation system, completely filling the pelvic elevation system. So right STAGHORN, right complete STAGHORN, and left में क्या लगता है आपको?
Sir, lower ureteric, it is lower ureteric stone, sir. I'm not sure.
So again, a radiopaque density in the right lower ureteric area,
Yes.
probably a lower ureteric stone. Anybody wants to add anything? Ojas?
So that's so. Can we comment with the STAGHORN stone on X-ray KOB? Like I would like to say a large radiopaque stone measuring around 8 centimeter on the right hand side, whereas on the left hand side, lower ureteric, there is a oblong opacity seen in the lower ureter.
Yes, you can call it STAGHORN.
Okay.
Why should you not call it STAGHORN? There is a renal pelvic component with multiple chelation components, so it is a STAGHORN.
Okay.
See, Ojas,
Yes, sir.
we are going to appear. You are going to appear for super specialty.
Yes, sir.
So you are already cleared your surgery. You know, we don't have to now talk like MBBS student. You understand? Now it
Yes.
is, you are sitting, consulting. If someone gives you this X-ray, you are going to say it's a STAGHORN calculus. That is the
Okay.
first thing which will come out from your mouth.
Okay, sir.
Ojas had also told Prashant that while describing such an X-ray, exactly how Maheshwari sir said just now, that because it is taking the shape of the pelvic elevation system, therefore it is suggestive of a STAGHORN calculus.
Okay, sir.
On an X-ray, you have to say that there is a right radio opaque density in the right renal region because of its location and because of the shape of mimicking a pelvic elevation system. It is certainly a STAGHORN calculus.
Okay,
So
sir.
you are saying that in one sentence, no? Therefore you can say that it is a STAGHORN.
Yes.
Maheshwari sir just repeated exactly this is what I had told Prashant.
Yes, sir.
Chali. So what next?
Sir, CT contrast enhance CT scan of kidney KUB, sir. CT urogram.
Why do you want contrast lens CT? Why not plain IVP?
Sir, firstly, sir, it will give the sir proper. It will give information about the functioning of the kidney, sir, and also tell about the anatomy of the kidney. That is why, sir,
That you will come to know on IVP also.
Sir, but sir, for IVP, it is better than the IVP, sir. Other informations are also we can get from the CT scan, sir, like skin to stone distance and retrorenal colon, and Horn's units we can get on the CT scan. And also, sir, there is yes.
Let's look
yes,
at the three things you have said. Let's
sir.
start with SSD. Why do you want to know SSD?
Sir, sir, for this stone, not for this stone, sir, because
So let's talk
skin to
about this
stone.
patient.
Yes,
So SSD is out. Second, retrorenal
Yes.
colon. Are
Yes,
you
sir.
okay? The third you said was Hounsfield unit. What is the Hounsfield
Yes.
unit? What do you expect in this patient?
Sir, it is going to hard stone, sir.
It is probably more than 1500. So why do you need
Yes.
CT scan?
You have said some good points, but like sir said, it should match with this case. Now you can see the
Okay.
density on this X-ray, right?
Yes, sir.
And how is the skin to stone going to make any difference?
Different.
So
Yes.
if at
Prashant,
all you
even
would
I
have
will be
said,
asking for a CT scan. I just want you to
correct,
explain
correct,
why do you
but
want a
how
CT
to
scan?
justify? How to justify?
Sir,
You could
CT
have
scan
said
will
that the
give, sir,
radiation exposure.
Yes, sir.
You could have said radiation exposure is more in CT, but however, with
Yes,
low
sir.
dose CT protocols or just CT urography, we can limit that. Okay. For then other information, go ahead. You talk afterwards also.
Sir, with CT urography, we can get the like exact functioning of the kidney and renal parenchymal thickness. We can get, sir. That
You see,
IVP
this is a
would
very,
not.
very debatable statement you have made. CT scan does not give you exact functioning of the kidney. How do you calculate function of kidney on CT scan?
Sir, if the dye is excreting from the kidney, that the function of the kidney is at least like 25% on the.
No, beta. आपने कहीं पढ़ा है ऐसा? I don't think what you are saying is right. You see, for IVP, they say that if on IVU the pelvic acid system gets opacified, then the function is minimum 30%. But the resolution of CT scan is so high that on DTPA you may find just 10% function and it may still opacify. So CT by opacification of contrast cannot talk about renal function.
Yes, sir.
So there are different ways of calculating renal function on CT scan, which you had just now mentioned, that is cortical thickness.
Yes, sir.
So they calculate the full cortical volume and based on that, they interpret the renal function. So we are not doing CT scan for function. That part is definite. Now, why do I need CT scan in this patient? Now, with such a large stone, what would be your probable treatment?
Sir,
Probably we will be thinking about PCNL.
PCN, yes, sir.
So PCNL planning is better done on a CT scan.
Yes, sir.
I can get proper coronal reconstruction. I can rotate the coronal image as well, see which calyx to puncture. So a CT scan will be more helpful for me in planning the treatment. I will get the surrounding anatomical details, one of which you should mention was whether there is any retrorenal colon. So CT scan is not being done for function. CT scan is being done to get the complete anatomical details and to plan your further treatment.
Yes.
And CT scan will also help you decide what the left side ROD is.
So most of the things are covered. Number one, Prashant.
Yes, sir.
Ojas, I am asking
Yes, sir.
all of you.
Yes, sir.
From looking at this X-ray, can you find out whether this kidney is functioning or not functioning? Huh? Ojas, can you find out?
Just by looking at this X-ray, sir.
No. Correct?
Then no, sir. No, sir. No, sir.
Suppose if you do IVP and this kidney is not excreting, are you going to become any wiser?
No, sir. We would rather prefer a CT urography, sir.
So that is one reason. Second thing, whatever Pankaj has said, that is all fantastic. Again, left side also you'll come to know whether there is any stone or it is not there. And one more thing is, this stone is very big. Now you can find out whether it is an intrarenal pelvis, because you
Yes, sir.
don't know apart from parenchyma and everything. So by chance, if you are thinking of opening up this patient, again CT scan will help you.
Yes, sir.
Fine. Okay. Go ahead. Paras.
Excellent. So these are the CT films.
Yeah, Ojas, you just tell us what are the findings
Yes, sir.
so that
Yes, sir. This is CT scan abdomen plus pelvis. Actually, CT scan abdomen plus pelvis. The liver appears normal. The spleen appears normal. The On the left hand side, on the right hand side, there is a large staghorn stone with reduced cortical thickness. Or whereas on the left hand side, there is evidence of a lower ureteric stone with the left side hydronephrosis. Both. Yes, sir. So right side is a huge staghorn stone with reduced cortical thickness, and left side there is a lower ureteric stone with hydronephrosis, hydroureter nephrosis. These are reconstructed images. Yeah. So right side huge staghorn stone, and left side.
Pankaj bhai, you think so?
Left side doesn't look hydronephrosis, sir. And probably that shadow may be outside, I think.
Correct.
If you see carefully all the pictures, there is no any hydronephrosis on that side. And right side there is a drainage, uptake of contrast, drainage of contrast, and staghorn stone.
Yes, sir. Left side.
Okay. Paras, just read the result.
It's a negative. Which are of with hydroelectric interaction recently passed left ureteric pelvis. Both kidneys show prompt confluence.
आवाज नहीं आ रहा है.
Yes, sir. So CT finding are suggestive of 8.3 into 5.8 into 3.7 millimeter size hyperdense staghorn calculus with a Hounsfield unit of more than 1300, occupying the right renal pelvic calyceal system completely. There's mild to moderate hydronephrosis on the left side with hydroureter in the entire extent. No obvious calculus or calcification is seen on the left side. There is prompt excretion of contrast in both the pelvic calyceal system. On delayed scan, both the ureter are opacified with contrast and well traced on the delayed section. No calculus in ureter is present in the scan.
Dr. Pankaj,
Yes.
please. Go ahead. Ask them now your questions.
So yes, so now you have got your information on CT. How do you proceed now?
So first, you would like a functional scan for this patient, sir. Actually, on the CT on the right side, the cortical thickness appear to be decreased. So I would advise a DTPA scan to know the right side function and then proceed, sir.
Then what was the advantage of giving contrast? Then why did you not do a plain CT and DTPA?
Sir, the DTPA would help, like, to obtain split function, it would be helpful, sir. So that will be one advantage of DTPA scan. So it will help to obtain the split function. And then, so if since the right side is still showing excision of contrast, so it is functional. So we know the split function, and for medical legal purpose and for explaining the patient that in the post-operative period, we will be monitoring this, how it improve, what is the later parameter. So for medical legal purposes and obtaining a baseline function of the or split function of both the respective kidneys.
Fair. Have we done the DTPA? I
Not,
doubt.
not done.
Not done.
It is not done.
Yes.
But Dr. Gite, is it mandatory to do the DTPA scan in this case?
Sir, if you read the report carefully, that report is showing there is a prompt uptake and prompt excretion from both sides of the kidney. So it is indirectly suggesting that this kidney is functioning. Okay.
Exactly.
If you see the film carefully, the ureter distal to the stone on right side clearly seen, upper ureter. So drainage across the stone or across the PUG is there. So the question of drainage is over. Question of uptake and excretion is over. So if you want to just know the exact functioning, differential function of that kidney and GFR as a baseline, which will be help if something goes wrong post-operatively, and if you want to compare, or some patients probably have some legal issues, in such situation only it will help. Otherwise, in such situation where the kidney is comparatively clear-cut, CT shows it is functioning and excreting properly, then probably I don't think there will be have any role of DTPA.
So yes, even I agree with you, sir. Okay, if the student asks for it and wants it, we can't say he will be able to justify it, but probably not necessary.
Yeah, but
We
whatever
have enough
justification,
information. Yes.
yes, whatever justification he has given, that can be accepted in exam.
Is acceptable. Yes. So if suppose he was thinking on the lines of DTPA, then probably it would have been better to do a plain CT and then ask for DTPA, rather than doing contrast CT and then ask for DTPA.
Okay.
I agree. If you are in doubt from the beginning, about a function, best thing is to do plain CT and DTPA, renal scan. Fine. Okay.
Chale, now suppose because you have asked for DTPA, now if I give you a scenario where the kidney function on right side is 15%, or the kidney function on right side is around 35%, would your treatment plan change?
So treatment plan would remain this, like, since it is functioning kidney, which we obtain on a CT scan as well, and 35% which indicates it is still functioning, treatment plan won't change. Just for a baseline, sir, and for medical legal purposes, it would be justified to do a DTPA scan. That's the
Sure.
only reason of doing a DTPA scan.
Good. Proceed. Now, how do you want to plan your further treatment?
The pain was on the left side, so the patient is symptomatic on the left side, and there's a left lower ureteric stone.
Right
with
side
hypoureter
pain.
nephron.
The pain was on
Pain
right
was on
side.
the right side,
Right
and left
side,
side
no
stone
ureter
is already
stone.
passed off as per CT scan.
Okay. Okay, so first of stone, but already, yeah. So right side is stage PCNL, and plus DJ stenting, and left sided we would like to do an RGP first during the initial part. If any abnormal detected, then accordingly proceed for DJ stenting on the left side.
What are you expecting on left side? What are you
So if
looking
any,
for?
it has said that there is hydrator nephrosis. So if so there was a stone in the initial part, and now there is still hydrator nephrosis. So whether there is a lower ureteric stricture, or whether the stone has, though the stone has passed, but then we would like to do an RGP to see if there is still an like, it could be because of either lower ureteric stricture or any edema at the side of the impaction of the stone. So in that case, an RGP would help us whether it needs any intervention on that side.
So you are absolutely going in the wrong direction.
Okay.
because if there is a stricture, you will not see. CT scan has very clearly said that ureter is dilated all along its length. So if there is a stricture, it will never be dilated all along its length. It will be dilated till the stricture. So unless this patient would complain of left flank pain, or on your clinical examination there is left renal tenderness, only then probably you are justified thinking about left side. Otherwise, I think the left story is over.
Okay.
Agreed, sir.
Right, sir.
Because the CT size of left hydronephrosis, except that hydronephrosis may be due to edema at the PUJ due to passage of the stone. No other things cannot be correlated with such findings on CT scan. Why there will be stricture? If the patient had stricture, then how stone will come gone through that stricture? And if it is formed due to the stone, the duration is very less. The hydronephrosis should, if it is long duration, hydronephrosis should be not up to that particular point or up gross or moderate type. Why there is a mild hydronephrosis? So ये thing correlate करके बताना है. ऐसा blindly बोलने से फिर क्या confusion हो जाता है.
Okay.
So the left treatment is over. Now, how do you plan, or what are your how would you think about your treatment plan for right side?
So right-sided, I would first the patient will explain that he has a right-sided large stone, and that that this is a large stone. It may not be dealt in the same setting. That on the CT scan, though the kidney is functioning well, but there is some decreased cortical thickness. So we have to explain to the patient that the stone burden is large. He might require multiple settings for the treatment of the same. I would offer the patient a staged PCNL. And proceed, sir.
So number one, you see, you never offer stage PCNL. You offer PCNL and take a consent for staging.
Okay.
In case suppose if you are going to finish it, and it is a very friendly system. If you look at the pelvic elevation system, okay, it is possible you may not need to stage it. So you don't plan a stage treatment. You plan a PCNL and then stage it if necessary.
Okay.
Fair. So now, if you want to plan PCNL, how do you, how will you start preparing your patient for the surgery?
So first, I will. The urine culture is showing no growth. So yes, so that has to be. So that is sent. Counts are normal. The INR is also normal. Also evaluate the patient from a cardiac front, whether he is fit for surgery and prone position. Then after obtaining well-informed consent, the patient would be taken to OT. First, in lithotomy position, we would do.
Would you arrange blood?
Yes, sir, we will arrange blood. Yes, sir. Blood will arrange. Yes, sir. We'll arrange for blood. Yeah. So, and a patient will be placed in lithotomy position. Right side ureteric catheterization will be done, and the ureteric catheter would be kept in situ. Then the patient will be turned to prone position. The patient might require multiple punctures here because the stone burden is large. I will attempt to do a standard PCNL with the ampulla sheath dilatation till 24 to 30 French, and initially lower calyceal puncture, if required, middle calyceal puncture, and using ultrasonic lithoclast puncture the stone and assess for the.
What did you say? Using ultrasonic lithoclast puncture the stone?
Sir, break the stone, sir.
Okay.
Fragment the stone, sorry. Fragment the stone. And then during as if
why have you chosen ultrasound what do you mean?
Sorry, lithoclast. Sorry, lithoclast.
Okay.
Lithoclast, and will fragment the stone. Also, during the part of the surgery, during the surgery, if required, multiple punctures may be done. During the surgery, I would like to maintain one safety wire and one access wire. During the part of the surgery, with intraoperative fluoroscopy, I will be assessing if there is any stone clearance. I might also make use of a flexible scope to assess for complete stone clearance, or do an RGP during surgery to assess if the stone clearance is complete. If you are planning that we are able to get obtain clearance in the single setting, or if the procedure is taking too long, then we would just put a nephrostomy tube and come out. Then DJ stand and a nephrostomy.
So simple question was this: how many PCNL you have done independently?
So a few PCNL I have done, say,
That's
How
all.
many you said?
Because whenever you are taking few
Two. Okay.
PCNL,
Few. Okay. Yeah.
So when you are taking this patient to the PCNL,
yes,
so you have not how you have counseled the patient? Have you counseled the patient?
yes, sir. Counsel that.
So in that counseling, you have to tell everything. That is infection, bleeding, intraoperative problem, colonic injury, pulmonary injury, need of ICU, need of blood transfusion, leakage, number of tubes from back, from front, periatal catheter, how many days, everything you have to tell. Number of tracks, needs of urgent procedure,
yes, sir.
needs of residuals, postoperative fever, postoperative sepsis. So these things can happen in any patient.
Yes, sir.
ये सब बताने के बाद में तुमको आश्वर करना है कि I will do my level best to tackle the stone in single sitting. If the stone residual is there, then you may need second sitting. ये सब चीजें तूने बताया नहीं, और पोस्ट ऑपरेटिव पेशेंट को आईसीयू में जाके 10,000 का पैकेज है, 1 लाख रुपए लग गया तो 90,000 पॉकेट से भरना पड़ता प्राइवेट में.
Yes.
So, Ojas,
Yes, sir.
can you do pyelolithotomy again?
So, yes, so we can offer open pyelolithotomy.
अभी देखो 8.5 into 5.8 centimeter stone with 1300 Hansfield unit. 8.5 मतलब काफी बड़ा है, and 5.8 width भी काफी बड़ा है. अब इसको ओपन करना, ओपन का क्या स्टेज है, लगेगा नहीं लगेगा, सिंगल सिटिंग में PCNL हो सकता है, नहीं हो सकता है, होगा दो सेकंड सिटिंग के लिए पेशेंट विलिंग है नहीं है, इसके ऊपर भी बहुत सारी चीजें, पेशेंट का इकोनॉमिकल स्टेटस, पेशेंट कितने दूर से आया है, एजुकेटेड है, तुमको समझ रहा है नहीं समझ रहा है. कुछ पेशेंट आके बोलते हैं साहब कुछ भी करो मेरा स्टोन निकाल के दो एक सिटिंग. फिर क्या करेंगे? तो थेराटिकली बुक वाइज और फिर प्रैक्टिकल वाइज दोनों का कुछ तो भी मिड पॉइंट पकड़ के पेशेंट को एक्सप्लेन करना पड़ेगा.
So, Ojas, I will ask you only one question.
Yes, sir.
What are the reasons you want to do PCNL in this case? Because he is operated earlier. And what are the factors, looking at the stone, you think that open can be done?
Because in this patient, each and every calyx is filled with stone. Both anterior posterior upper, both anterior posterior middle, and both anterior posterior lower. तीनों कहीं पे भी जगह खाली नहीं. कोई एक पंक्चर से कितना टॉर्क आएगा, सब चीजें निकालने के लिए कितने एक्स्ट्रा पंक्चर लगेंगे. ऑलरेडी पाइलोलिथोटोमी हो चुकी है, इंसिजन है, ट्रैक बनाने के टाइम पे कुछ इंजरी होंगी, कोलन कहाँ चिपके वाला है, ये सब चीजें ध्यान में रखते हुए PCNL is one way of treating this patient. So और कुछ ऑप्शन है क्या इसमें, या फिर PCNL ही है?
Just we understand, na? So you
Yes, sir,
tell
yes,
us
sir.
what are the advantages and disadvantages of PCNL in this case, and what are the factors which will help you to decide that yes, you also can, in this case you can do even an open surgery.
Nice.
So first come with the advantages and disadvantages of PCNL in this case.
Yes, sir. So the patient has undergone the previous surgery. So in advantage, this case, PCNL would be a less morbid procedure, and he has a past, but that would be an advantage. Disadvantage would be that since there is a past pyelolithotomy surgery, but
वो जो जान दो. पंकज सर आपका ओपिनियन बोल दो.
Let the other students try.
Yeah.
What would you do, Abhishek?
Abhishek,
Sir, this is a previously operated case, sir. So the puncture and this is a large Staghorn calculus, sir. So access through a PCNL can may be difficult, sir, in this case because of the surrounding fibrosis and the large size of the stone. So that will be a disadvantage of PCNL, sir. Whereas PCNL being a minimally invasive procedure, sir, less morbid as compared to an open surgery, that will be the advantage of PCNL, sir, in this case. And sir, second disadvantage would be that the PCNL might have to be staged, and that will add to the morbidity and the cost of the patient, sir. That is one disadvantage of PCNL.
Yes, so PCNL is possible, but PCNL is going to be technically demanding. The reason being, as Dr. Gite Saab said, that the minimum tracts I see in this patient is 4, probably 5. Means even if I go through the upper calyx will give me the upper calyx, renal pelvis, and 1 lower calyx, and then the 2 mid calyx bifurcations may need 1 puncture. Okay, so I am looking at least 4 punctures or probably 5 punctures in this patient. So PCNL is possible, but it will need multiple tracts. It will need expertise. It will need say, because of multiple tracts, the risk of bleeding and complications increases. Open surgery would be a good option because most of the stone bulk is medial. There is less lateral stone bulk, especially if this patient has an external pelvis, which I think on CT scan he has. A pyelolithotomy could be a good option. The only drawback of pyelolithotomy would be that because it's a previously operated, you expect adhesions even during open surgery. So both the options are difficult. So you should give an answer based on your expertise. So you can say that in my training, I have seen complex PCNL and I am comfortable doing it. So you can say PCNL, or you can say in my training, I have seen good amount of open pyelolithotomy and I think I can do it. So you can say pyelolithotomy. Understand one thing from exam point of view, don't be very rigid for any answer.
Yeah.
Don't stick to just PCNL or pyelolithotomy. If somebody says pyelolithotomy for this particular patient, absolutely not wrong. It's a good treatment.
Sir, ECIRS.
Now, the issues with ECIRS is that one, we will need to do a supine procedure. And for such a huge stone bulk, supine PCNL may be awkward. And ECIRS will definitely help in reducing the number of punctures.
Okay.
only I agree with Maheshwari. Only thing is, in this case, as you said very rightly, the stone is more medially. It is extra-renal pelvis. Infundibulum is not narrow. So the chances of while removing the stone, the bleeding will be comparatively, we can avoid. That is one thing. So apart from fibrosis and dissection, which may be difficult, all other criteria are good enough for open surgery also.
True. You will not need anatrophic as you may need if there is infundibular stenosis.
Correct.
You will be able to do it with the extended pyelolithotomy.
So now you know how to answer after listening to Dr. Maheshwari. So let us see which surgery was done. Okay, Paras, just show them. Paras.
He is muted, sir.
Wow.
So open anatropic nephrolithotomy was done for this procedure and the stone was.
Now this case is done by Dr. Gite. Gite sir, आपने क्या किया था?
Sir,
आपने pyelolithotomy किया था कि?
No. Intraoperatively, I have dissected ureter right up to the hilum, and there is very minimal pelvis outside the renal parenchyma. So it is like more probably half centimeter or 1 centimeter. So doing a pyelolithotomy intraoperatively is just impossible. So only way I have is to open the kidney. So opening the kidney by multiple places I thought at that particular time doing a anatropic nephrolectomy will be good in this case. And along the border lines, I bivalve the kidney. In between, you told there is infundibulums are narrow, but here infundibulums are of wide length, but here infundibulums are too narrow. So in spite of opening the kidney, removing of stone is very difficult. So I have to do a infundibulotomy, intraoperatively open infundibulotomy.
Wow.
Two infundibulotomy under vision, then repair of that infundibulum and repair of the kidney with removal of a complete removal of the stone with DJ without PCD, with PCD.
And what about
patient,
this thing? You had clamped the vessels?
no. I
You are
have
not.
mobilized it all around, placed in one hand and operated with another hand. And the total operating time for stone removal is 30 to 35 minutes, and amount of bleeding probably 500 ml.
Okay.
Excellent.
Very good. So now any questions? Otherwise, we have got one short case, an interesting case which can we can discuss today. Dr. Pankaj, you want to ask anything?
No, I think I'm. This is enough.
So only one question: after doing this surgery, how will you follow? Prashant.
Yes, sir. Patient should be counseled regarding the fluid intake and dietary modification, sir.
No. Patient
Yes,
is
sir.
already
Yes.
operated. Now
Yes, sir.
day 1, day 2, what are the things you will look for?
Sir, firstly, I'll look for drain output and his intake output charting should be monitored, sir. And on second day, sir, after 24 to 48 hours, sir, Foley's can be taken out, sir, and look for the drain output. If drain is not coming more, then we can take out the drain, sir.
Any blood investigations you like to do?
Yes, sir. Post-operatively CBC and serum creatinine, I would like to do, sir. For this
So now
patient.
sir said 500 cc of blood loss approximately.
Yes,
so
yes,
how much
sir.
hemoglobin drop you are expecting?
Sir, 2 to 3 grams, sir.
So when will you like to give him blood?
Yes, sir. I would like to give him the blood, sir, because but yes, sir, I would like to give him. Yeah.
Abhishek, you will give blood? His hemoglobin is 14.
No, sir. So blood I will not give, sir. Hemoglobin. No, sir. Blood I will not give.
So you'll see if the hemoglobin
Firstly,
is less
CB.
than
Yes, sir. Depending
either
on
the
the
pulse rate,
CBC
BP
value.
low. If you are thinking
Patient
that
is yes, sir.
yeah, your estimation is not proper, or if you think that blood loss is more, then you will give the blood. Otherwise, you will wait. Correct? Okay.
Yes.
I think we should go ahead with the. What is Dr. Maheshwari? Is it necessary to do DTPS scan or something after this big surgery?
No, it is not necessary.
It's not necessary.
No.
Okay. Bharat, next case.
Yes, sir. Yes, sir. Next. Okay. प्रशांत सर आपको स्क्रीन दिख रहा है?
नहीं, it is buffering. पारस लॉग आउट करके लॉग इन करो एक बार.
Yes.
But we can clearly see it. We were seeing it.
Sir, but his PPT was not visible.
अभी दिख रहा है?
No, it is showing has started screen sharing. Just
No, it is seen. 65-year female housewife,
Yes, sir.
resident of Mumbai.
Yes.
Prashant, your internet is slow.
So this is a case of a 65-year-old female housewife resident of Mumbai presented to us in emergency with right flank pain since 5 days, fever with chills since 3 days. Abhishek sir?
Yes. Okay, so I'd want to elaborate on the presenting complaints. Right flank pain since 5 days. What is the onset, duration, progress of the pain? What is the character of the pain, severity of the pain? Any aggravating or relieving factors? Any radiation? Any relief on medications? Other than that, I would want to ask about any associated symptoms associated with the pain. Fever, as she is giving a history, fever with chills. What is the onset, duration, and the progress of the fever? What is the grade of fever? Is it relieved by medications? Other than that, I would ask history of any associated hematuria or lower urinary tract symptoms associated with this pain and fever, and any previous history of similar episodes, any previous history of any surgery or instrumentation done in the past, or any medication history. And in the past history, I would want to ask about comorbidities, more specifically diabetes. And other than that, I would want to ask of Mm, yes, sir. And yes, sir. And other than that, any yes, sir. That will be all.
Why were you so specific about diabetes?
Sir, elderly females or 65-year-old female with right flank pain, sudden history with fever with chills. Sir, the first thing that comes to my mind is an infective etiology, sir. In an elderly female, sir, this could be because of any infective pathology, or sir, maybe because of sir, sir, papillary necrosis causing obstructive uropathy and then infection, sir. So in that lines, I was thinking.
Perfect. Good.
So patient was asymptomatic 5 days back when he started having right flank pain, insidious in onset, progressive, dull aching, non-radiating or referring, associated with the sense of nausea and was associated with vomiting. Patient also have history of fever with chills. Pattern could not be commented. There was no documentation of fever and the fever was relieved by medication. There is no history of trauma, urethral instrumentation or surgery in past. There is no bleeding disorder or anticoagulant therapy. Patient is not on anticoagulant therapy. There is no lithuria or hematuria. There is no history suggestive history of facial puffiness, pedal edema, or breathlessness. There is no history of recent sore throat or skin infection, jaundice, headache, or backache. So patient is a known case of diabetes mellitus and is on medication. Personal history, patient is mixed by diet, no allergy to any food or drugs. Sleep is normal and undisturbed. No addiction to any form of tobacco or alcohol intake. Family history is nothing contributory.
So any change in your thinking? What are you thinking now?
Sir, she's a known case of diabetes. So yes, sir, I'm still thinking in the lines of any infective pathology, sir. And there is no history of lithuria, there is no history of hematuria, no previous history of any stone disease or intervention in the past relating to stone disease. So, sir, stone disease, I will, I'm, sir, keeping it in on a back foot at this moment. And other than that,
so when you say
yes,
infective pathology, what do you mean?
sir, specifically pyelonephritis, sir. Pyelonephritis, or sir, any urosepsis secondary to papillary necrosis and causing obstructive uropathy. Other than that, sir, any infection, any cystic disease which may be infected and then causing such this kind of fever, sir. So these things I'm thinking, sir.
Okay. I would still feel that you should still keep the diagnosis of calculus disease somewhere in your list.
Okay, sir.
Means these things, they increase the possibility of calculus disease, but they don't rule out.
Right, sir.
Go ahead, please.
Yeah, I agree with Dr. Pankaj Maheshwari. Stone, you must keep it in mind.
Okay, sir.
On general examination, it is grossly normal. In abdominal examination, there's only right renal angle tenderness.
Of febrile, right? Okay.
Okay. Ojas, you want to say anything? Ojas, you want to comment anything? You want to ask anything?
No, sir. So she was off febrile, right? That's off febrile. She was right now off febrile. And has she received any antibiotics in the last 3 or 5 days by the any other treating physician?
Negative medication history, and at present she's
Afebrile.
afebrile on
Okay.
examination.
Okay. So then I will proceed with investigations.
So now what do you want to do?
So initial
Sir,
routine investigation. Yeah. Initial routine investigation form of complete blood count, serum creatinine, urine routine microscopy, a urine culture sensitivity, and also go ahead with the ultrasonography KUB as a extension of a clinical examination.
Yes, you want to do ultrasonography KUB or you want to do ultrasonography?
Abdomen
post
studies. I'm
abdomen
sorry,
and
abdomen blood studies. Abdomen blood studies. Go for abdomen blood studies.
And why? Why not KUB and why abdomen and pelvis?
So there could be other etiologies for the pain on the left side. So we would like to rule out the same, sir.
That is, I will say a second reason. What else? See, if you do only a KUB, there are so many radiologists. They will just focus on kidney, ureter, bladder. They will not tell you anything apart from that. So any other complication secondary to this, you may miss. So always ask for full abdomen and pelvis.
Yes, sir. What will we miss is so other pathologies in the form of as in related to the spleen, liver, and all that should be ruled out. And what we would miss in just a USG KUB, sir?
Sometimes they don't comment perinephric collection or some collection in pelvis, so many things.
Okay.
Because they just focus on kidney and ureter and bladder.
Okay, sir.
Aras, go ahead, just show them.
So urine routine microscopy, pH is 6.5, sugar is present, RBCs are 18 to 20 per high power field, WBC is 30 to 40 per high power field. Urine culture sensitivity is sensitive, it shows growth of E. coli, 10 raised to power 5 colony forming unit per ml, sensitive to fluoroquinolone, cephalosporin, and nitrofurantoin. On the blood report, TLC is 27,730, creatinine is 2.32.
Or just
Yes,
what
sir.
you want to do.
So as we have sent first the urine culture, then we will be starting on antibiotics. So first urine culture. This was urine culture after or the previous urine culture. This is
Whatever
first
it is, this is a urine culture. You got it. The count is 27,730.
Yes, sir.
And
I
the
will admit the
creatinine is
patient.
2.32. Why
Yes,
the
sir.
creatinine is raised?
Sir, now in this case, the creatinine raise could be one is that patient has a infective pathology, which we would like to evaluate on the ultrasonography. Also, the patient is a known diabetic since many years. So diabetic nephropathy could also be the reason for the raised creatinine that we will evaluate after doing an ultrasound as a first preliminary investigation. I will first admit the patient. Urine cultures and already have been sent. I'll start the patient on based on the culture report, cephalosporins and on IV fluids and paracetamol if the patient is having fever.
Which cephalosporin?
So I will start the patient on cephalosporin sulbactam.
Which one?
So cephopyrazone plus salbutamol.
Why Salbactam?
So the patient is diabetic and uh, this or just plain cephopyrazone could also be done. So just maybe just starting on plain cephopyrazone. You could start that.
Now the creatinine is raised. It will
Yes,
be
sir.
wiser to use Salbactam.
No, sir. We'll just start on plain cephopyrazone, sir.
Yeah. So if patient is sensitive to only cephalosporin, just start that. No.
Yes, sir.
Why we want to add extra and cause unnecessarily problem?
Yes, sir. Just
Correct?
start on yes, sir. Yes, sir. Just start on cephopyrazone, and after the patient and start on IV fluids, with stick intake output charting, monitoring of the sugars, and then ask for an ultrasonography, where as a preliminary investigation to proceed, sir.
So creatinine is can be high raised because of, as you said, diabetic nephropathy,
Or infection and
infection,
dehydration,
dehydration, and obstruction.
obstruction also. Yes, sir.
You are suspecting either is this a
Yes, sir.
stone
Yes, sir.
disease or there may be papillary necrosis.
Yes,
You
sir.
are suspecting something.
Yes, sir.
So there are chances. Fine. Okay. Show ultrasonography. Come on, just.
Yes, sir. So this is ultrasonography abdomen plus pelvis. The liver appears normal. The right kidney, there is. Actually see properly. Right kidney.
There is, sir, this fullness noted in the right pelvic elevation system,
PCS there
right
is
PCS of the right kidney, and left kidney appears unremarkable, sir. And other than that, there is some dilatation of the intrahepatic biliary radicals also. Other than that, yes, sir, this is all I can make out of the static images of the
so the
ultrasound.
last image on the
Sir,
right hand side.
just
Not sure what is that. The last image on the right hand side, the lowermost film. I'm not sure what is that. Collection.
Paras, just read the report. Paras.
Yes.
Yeah.
So the right kidney is slightly low placed with and measure 10 into 5 centimeter, and a short segment of ureter is also dilated. No ureteric calculus is visualized. There is a right ovarian cyst of 2 into 1.4 centimeter.
Left kidney normal. Okay. Okay. So we'll.
So fine. Ojas, next what?
So plain CT KOBs. Now the lower ureter is not visualized. So I will advise for a plain CT KOB for this or a plain CT abdomen plus pelvis for this patient, sir. Because the creat is raised.
Okay. Sure.
X-ray. X-ray. Right side.
CT.
Yes. Okay. So left side, what is that? Stomach is distant.
Yeah, पढ़ के बता. Anyway, Ojas, can you see some specific thing on the right hand side?
Right hand side. So the
so
right
there is
lower
the
liver is
right Kidney
of the
is
liver is
obviously
less.
bulky, sir, and there is significant perinephric fat standing on the right side, and sir, there is air foci that is noted on the right kidney, sir,
Yeah,
extending
in the
into the
parenchyma.
pelvic calyceal system and also to the perirenal space, sir.
Perirenal space.
Yeah, I think it is extending to the perirenal space also.
Okay, read. Paras, read the result.
Yeah. So the CT, plain CT KUB was done, and it was suggestive of a right bulky kidney with perinephric fat standing, posterior subcapsular and perinephric collection with a air foci measuring about 3.3 into 2.3 centimeter. These findings represent emphysematous pyelonephritis class 3A.
Ojas, give me a total perfect diagnosis.
There is no stone. Okay. Yes. So right-sided emphysematous pyelonephritis class 3A. Yes, sir. There is no
With
stone.
what?
With the right class 3A.
Diabetes.
With diabetes and
Okay. With diabetes. What's it? No. With diabetes mellitus. Yes, sir.
and
And sir, acute renal failure.
it is acute renal failure. Dr. Maheshwari, now you please. Last time also you had talked to them and discussed about septicemia, urosepsis, urinary tract infection, acute renal injury, and CKD. So, Pankaj, can you just take over and ask them?
Sure. So why don't you complete your diagnosis? So you said emphysematous pyelonephritis type 3A with, instead of diabetes, I would probably say uncontrolled diabetes
Uncontrolled diabetes. Okay.
with
Acute renal injury.
with right obstructive uropathy with
Acute
CKD.
renal. Okay, CKD.
Okay. We do not know the previous creatinine.
Previous creatinine. Okay.
So whether it is acute or chronic or what it is, we have no idea.
Yes, sir.
You agree with me?
Yes, sir.
Okay. So now what next? So will you call this as urosepsis?
No, sir. For urosepsis, there has to be another organ involvement. So this will be urinary tract infection itself. Where there is another organ dysfunction along with the kidney, along with the urinary tract system, then we'll call as urosepsis.
Fair, absolutely correct. So just because the patient comes with fever and obstructive uropathy, do not call it urosepsis. There has to be one more end organ failure which is related to this infection, which is caused by this infection.
Yes, sir.
Okay, proceed please.
So this patient will continue the IV antibiotics, will require drainage in the form of either a degestenting or a percutaneous nephrostomy to drain the collection.
Don't say either. The question is, what do you want to do?
So in this patient, the patient has a subcapsular collection with probably with thick pus. So in this case, I would prefer for a percutaneous nephrostomy, which would help to assess the function of the kidney, help to drain the pus, will have lesser chances of getting blocked, and will provide better drainage. However, it has a disadvantage of chances it will be a more increased mobility of the patient as a nephrostomy to carry, and it can get dislodged, dislodged. Whereas the advantages for and also the advantage for a nephrostomy would be that can be done bedside. In case of degestenting, the advantage would be that it would be an internal tube, so less chance of getting dislodged and and decreased mobility. However, more chances of getting blocked, and it may not be able to drain the the collection which is there outside. There is another. Yes, sir.
Why has the collection formed outside?
Yes.
So actually, initially when the organisms multiply, they would they would invade through the parenchyma and then into the capsule.
Here,
Because of
the problem is kidney is bulky and no hydronephrosis. Collection is subcapsular and perinephric. That is only 3 into 3 into 3 अगर पकड़ा गया तो 3 3 9 9 3 27 15 ml कलेक्शन होगा मैक्सिमम.
Yes,
ठीक
sir.
है, 15 ml
Yes, sir.
कलेक्शन के लिए तुम कहाँ कैसे पे स्टडी करेंगे भगवान जाने. दूसरा पीसीएन करना है तो हाइड्रोनेफ्रोसिस नहीं है. एक्यूट पाइलोनेफ्रोटिक किडनी सोलन किडनी है. ऑब्स्ट्रक्शन सस्पेक्ट कर रहे हैं. डिजेस्टेंट अगर बोल रहे हो तो दैट आई विल एक्सेप्ट विथ.
Absolutely.
इतने छोटे कलेक्शन के लिए तुमको बहुत ही लग रहा है तो एस्पिरेट कर लो. अगर तुमको निकालना ही है तो उतने छोटे कलेक्शन में ट्यूब रखना और वो मेंटेन करना, और ये बड़ा डिफिकल्ट काम.
Plus, with the new classification of emphysematous pyelonephritis, there is, you said 3A, so there is pyelonephritis.
So digestant may not help in draining that collection until and otherwise it is communicating with PCS and it is formed due to some leakage by breach in the PCS. Then only digestant will help. Otherwise, that collection may get reabsorbed with the cover of antibiotic, or it may convert it into the abscess and increase. So we have to do follow up with some sonography, clinical examination, and if it is increasing, then you can think about placing the percutaneous drainage, not a nephrostomy.
Okay, drainage. Okay.
Rather, again, I'll tell you here, you just say in exam what you do. I'm sure in your center, I don't know where you are working, but in your center, the treatment would be digestant.
Yes, sir.
100%.
Just don't talk of PCN, please.
Okay.
Okay,
You know-
as Dr. Gite said, placing PCN in this patient is extremely difficult. Because of the inflamed kidney, the risk of bleeding will be very high.
Okay, sir.
So digestant and PCN will be, and you know, there is ample literature which has said that the results of both digestant and PCN are exactly the same.
That is
Yes.
what I was saying, sir. With the new classification and all, there is so much literature saying that internal drainage itself is good for emphysematous pyelonephritis.
Okay, sir.
You know, Pankaj bhai, you know what is the problem?
Yes.
We are all mistaking this with a pyonephrosis. So earlier when we are doing the cases of pyonephrosis, we tell them, or the obstructive uropathy, we tell them that PCN is better. The same thing the same logic they are applying over here. That is the
Exactly, sir.
problem.
That's why I have read the report first.
Yeah.
Because there is no hydronephrosis, there is no
Exactly.
pyonephrosis.
Also,
So-
if it was a sick patient with a hydronephrosis, low pulse, low BP, something like that, you would have said on weekly basis, ultrasound guided, I will put PCN, you would have been justified.
Okay,
No,
sir.
but PCN for what? PCN if there is a pyonephrosis.
Correct. If there was pus and if the patient was
Now, if there
unstable,
is a connection in the cortex or in the perinephric space, and if you put a PCN from middle calyx or upper calyx or even just above this collection, how it is going to help?
Okay.
Even if you want to
guys,
put,
you
then
have to
put a drain
correlate.
inside or aspirate this collection.
So you have to correlate everything. The
Yes.
patient's findings, the CT findings, hydronephrosis hai, nahi hai, what is the collection, how much it is. Like Gite sir said, it's such a small collection. So antibiotics se hi resolve ho jayega.
Okay, sir.
So in this particular patient, I would not accept anything other than a digestant.
Now,
Agree. I think all of us agree.
suppose this patient has come in urosepsis. His BP is also very low, 70. Okay.
Yes, sir.
And he is in a very bad condition. What you will do?
So in that case, again, we can still do a digestanting. So we can still do digestanting under local anesthesia.
So why you want to do digestanting?
We are suspecting obstructions to drain the system, and along with the coverage of the antibiotics. So that will help to control the infection, the systemic infection, and this will help to cover with the source of infection. That will help to drain the system.
Why not to do nephrectomy immediately?
So it's an inflamed kidney. The patient would not be able to tolerate the surgery. The patient is currently in hypotension and sepsis. So in this case, initially we could attempt a digestenting and antibiotics. If the patient is not responding, then we might consider, but initially it would be just involving a digestenting and drainage.
See, there are literature papers which are showing that if you do digesting or drainage, and even if after that you have to do nephrectomy, the patient's condition will improve, and the chances of mortality, the rate of mortality is less after doing some drainage. So even if the patient is in a very bad condition, you do nephrectomy immediately. Earlier, we didn't have all this concept. So 25 years back, when the patient used to come, we knew that if we don't operate, mortality is 100%. If we operate, mortality was anything between 70 to 80%. So we were taking our chance and we were operating. Then people realized that by doing digestenting, even though we have to go for a nephrectomy, patient is well stabilized, and chances, mortality rate is much less. Okay, but now with the very good antibiotics and this drainage, there are chances that we may save this kidney.
Yes.
Pankaj bhai, your personal experience?
Yes, I 100% agree, sir. These days, nephrectomy is very, very rarely needed. Rather, I would say in probably last 5 years, I have not done a nephrectomy for emphysematous pannephritis. And most patients respond very, very well to digestant, good control with antibiotics, control of sugar, and overall resuscitation. So speak of all four things, say fluid resuscitation, antibiotics, glycemic control, and drainage.
Yes.
And then you would observe these patients. Depending on how he progresses, you may repeat a sonography after 48 hours. If the collection has reduced, you continue what you are doing. If the collection has localized, then you may consider either sonography guided aspiration or CT guided pigtail placement. So the further treatment will be based on how the patient progresses on your initial treatment.
Yes.
So, Ojas,
Yes, sir.
Patient is improved. Everything is fine. Okay, the pulse, BP, count has also reduced. What will happen to this kidney?
So in the initial setting, it will progress to a stage of inflammation to then it will progress to a stage of fibrosis, and so then initially we would give an antibiotic course for at least 10 to 14 days, or rather continue till the patient is off febrile. Patient has submitted with yes, she was off febrile, but then we'll continue IV antibiotics for minimum of 14 days. And then with serial USG monitoring about the collection and the other and the creat and the counts and hemodynamic stability for fever and everything. So and later, and also with the creat and CBC, and then
Okay,
we would
patient's creatinine has come down to 1.8. The
yes, sir.
count is absolutely normal. Patient is febrile. Everything clinically, she is absolutely fine. And there is a digestant inside. Output, everything is very well maintained. So you'll discharge her.
Yes,
Correct?
sir. Yes, sir.
When you'll call her and with what investigations?
So after 14 days of antibiotics, I will discharge her. I would ask her to monitor her sugars regularly. I will call her after. I will first tell her that she will be sent home on oral antibiotics. That she has to maintain strict glycemic control. She has to monitor her sugar. Also visit her endocrinologist for follow-up for better sugar monitoring. She will take care of her diet, like diabetic diet, and then she would maintain perineal hygiene, and then she would follow. I will ask the patient that in case of fever, again if she spikes again, or if there's any hematuria or any other if the pain increases, then she should report back immediately to the emergency department, or otherwise she could follow up in 7 days with a ultrasonography and a complete blood count and a creatinine and sugars charting of the last previous week.
And you are not interested in urine routine.
Sir, urine, yes, sir. Urine routine also, yes, sir. Urine routine also.
Okay, urine
Urine
routine shows innumerable pustules.
So if so, that should be initial. She will have that. So we will just observe clinically whether she has fever or other counts are raised.
After 1 month, she comes innumerable pustules.
So then, if she is still asymptomatic, no fever, then we will still just say that we'll keep a watch and imaging if required.
So
If
if you are
based on
not going to decide based on urine routine, why are you doing urine routine? You are deciding clinically, then why are you doing urine routine?
so to look for like the patient can end up in uh,
Dr. Maheshwari is asking you,
yes, sir.
is there any significance of doing urine routine or just because
For-
you are a
For
urologist,
proteinuria, for proteinuria and for mainly for proteinuria and hematuria.
not for
Yes.
pustules?
देखिए, एक बार अगर हमें पता चल जाए कि हम गलत रास्ते पर जा रहे हैं तो फट से वापस आ जाइए
Okay,
और अंदर डीप में मत जाइए.
yes.
So it is best to say कि no sir, I agree. As long as stent is there, there will be pyuria, so my treatment will not change.
Okay.
And
Okay.
go. Now the moment you say now, what did you say? Proteinuria.
Yes, sir.
So you have really dug a deep hole.
Yes, sir.
Okay.
Okay, so now when you will remove the DJ stent?
Sir, after 6 weeks, that if the patient is clinically all right. 4 to 6 weeks.
So Dr. Gaurang Shah had asked you, what investigation will you do before removal of the stent?
Why you have placed the digestant?
For drainage of the system.
So why it is required to drain the system?
Because there was some obstructive pathology, so that would we would follow up the patient with a USG, and then based on that we'll decide whether when we can remove the stent.
So will USG
The resolution of the hydronephrosis, resolution of the
obstruction?
infection. Yes.
Will USG show you the obstruction?
No, sir, but we can see for the hydronephrosis and whether the collection and all has increased.
Hydronephrosis will reduce, and as it is, this lady never had hydronephrosis.
So for the collection and for the collection also, if it is increased.
Just hold on. What
Yes, sir.
sir is asking you is that now patient has stabilized. Everything is good. We have reached a stage where we want to remove the stent.
Yes, sir.
So before removal of stent, what investigation will you do and how will you plan stent removal? हो गया, कलेक्शन खत्म हो गया है, क्रिएटिनिन नॉर्मल आ गया है, टोटल काउंट नीचे आ गया है, कल्चर नेगेटिव है.
We would do a
Do you want to do a plain CT before removal of the stent?
yes, sir, a plain CT, yes.
So what will plain CT
A plain
show you?
CT, yes. Plain CT would show us any to look for any radiolucent stone which was missed initially, maybe.
Just if your
And,
prior CT, you have done a prior
Yes,
CT.
yes, sir. Yes,
So
sir.
what is the cause for obstruction?
So
So you have placed
papillary
the digestone to relieve the obstruction, correct?
Yes, sir. Yes, sir.
So why there is obstruction?
So probably
So any
papillary
patient of
necrosis.
emphysematous pile nephrosis.
Papillary
What is the
necrosis.
triad of emphysematous pile nephritis?
Pain, fever, and
Obstruction.
obstruction.
Diabetes, infection.
Infection. Yes, sir.
So obstruction is usually stone. Diabetes uncontrolled and infection. So these are the triad.
Yes, sir.
So either it will be stone or it will be
Papillary
papillary nephrosis or papilla.
necrosis. Yes, sir.
Correct.
Yes,
So
sir.
if it is stone, you have to do the treatment of stone because you have not done anything for that stone.
Yes, sir.
So if you think this kidney is non-functioning, then the treatment, isolated treatment of stone may not be required. If
Yes,
you
sir.
think this kidney is functioning, isolated treatment of stone is required. Okay.
Yes, sir.
If renal papillary necrosis is there is no stone in prior CT scan, and if you are suspecting renal papillary necrosis, you have to just think, you have to just investigate in terms of that it is clear. Papillary necrosis is get clear.
Yes, sir.
So how will you see that all papillas or there will not be any papilla inside the ureter, not causing obstruction? Stain निकाल के क्या करेंगे? Confirm कैसे करेंगे?
Doing an RGP first, retrograde pyelography, and then
That's all.
yes, sir.
तो
When
दो ही
the
चीजें
patient
है
also
ना,
sent him on. Yes, sir.
किस चीज के लिए
When the
स्टेन
patient
डाला था, ये अगर तुमको पता है तो ये आंसर पता हो जाएगा आगे का.
yes, sir.
So just we tried to confuse you a bit. Now, if the prior CT had shown a stone, then you do a plain CT again.
Yes,
If prior CT had not shown a stone, then you remove the stent, do a retrograde pyelography, and if suspicion, do a ureteroscopy and remove the papilla.
Exactly.
yes, sir.
Okay. So CT scan is not needed in every patient. It will be needed only if the prior CT showed a stone.
Stone.
Okay.
Yes, sir.
Shally. Good, I think.
So we won't do a nuclear scan in this case, or should we do just asking, sir?
No,
Just a
so
doubt.
the same. Now you have done everything. You removed the stone. I mean, you removed the stent.
Yes, sir.
Okay, Ojas.
Yes, sir.
Now how will you follow up?
Sir,
his question, sir. We will answer his question first. There is a role. What is the role of
No, that
renal
is what
scan
I'm
in this
coming.
case?
Dr. Gite, I'm coming to that only. I'm
Okay,
I'm
sir.
getting answer from him only.
Okay,
Okay,
sir.
Ojas. So you have removed the stent. Now
yes,
you
sir.
just leave this patient behind and you will say her, now you are absolutely fine, go home, enjoy.
No, sir.
So what will you do?
So again, the patient would be explain about strict glycemic control and a report in
No,
case
no,
of fever.
don't
Okay.
tell me again and again.
Yes, sir. So we'll do a nuclear scan, a functional scan to assess what is the function of that kidney. A nuclear
After
scan to
that,
assess the right side kidney function.
if it is showing that GFR is only 7 or 8 or differential function is 20, 18 to 20. Now what you'll do?
If the GFR is 7, as in less than 10, and differential less than 15%, then the patient would be advised for
17 to 18. I'm saying 20.
17 to 18.
You would understand
20.
this patient has creatinine raised. She has got diabetic nephropathy.
Yeah, so in that case, the patient, we would conserve the kidney. In that case, we'll conserve the kidney, maintain the
The
patient.
urine routine is showing innumerable pus cells. This is a practical thing. I'll tell you. When this patient follow up, I'll show you.
So in this case, we will follow up the patient with, as in, we will go for a conservative approach. We'll maintain the patient on antibiotic prophylaxis and glycemic control, and assess with a USG at maybe 3 months to
No.
or if
So
it's medically.
now you answer me when you will do DTPS scan and why you will do it.
So we'll do it after
So this
6
patient
weeks.
has got continuous pus in urine. Sometimes she is getting little symptomatic. And now if you do DTPS scan, why you want to do a DTPS scan? To decide whether you want to do something to this kidney or you don't want to do something. Suppose this kidney is showing good function, 30 differential function is 30.
Yes, sir.
You will definitely do something reconstructive or something. You will want to save that kidney. So you'll go out of the way to save that kidney, right or wrong?
Yes, sir. Yes, sir.
But if this, because you don't want other kidney to suffer, you cannot just sit on that innumerable pus cells. Now, if the kidney function on this side is not good, so even though creatinine is high, raised, left kidney is not in a good condition, it is also compromised. But to save that side, you might have to take a decision. So clinically, if you think that this kidney is giving trouble, or if there are innumerable pus cells, and you are in dilemma how to treat it, then you will do a DTPA scan, and then you will take a call.
Okay.
Gite sir, आपका और Maheshwari, what is your view? How to follow up and what to do?
Sir, in this patient, because the lady is diabetic and already the creatinine is high, irrespective of what my urine routine shows or my DTPA shows, I may not consider nephrectomy unless there is an active source of infection there which is not getting cleared conservatively. So my plan in this patient will be to, as Ojas was saying, a strict control of diabetes, maybe a long-term suppressive antibiotic, and follow her up with sonography and creatinine. In all probability, sir, I may never consider nephrectomy in this lady, so I would not go that line. That is what I feel, but let's see what Dr. Gite says.
Sir, the post-operative follow-up, probably what we were doing at our center is depend upon the during treatment CT scan parenchymal damage. In this patient, the overall parenchyma is good, except some subcapsular collection. Suppose this emphysematous pyelonephritis is of type 4 and type 5 kidney parenchyma is not seen, wherever there is gas, distorted parenchyma. In such situation, we have to go for, I personally feel, renal scan in follow-up, as well as anatomical investigation in terms of CT scan if creatinine is normal, and if creatinine is not normal, non-contrast CT scan. In such type of cases, there is a permanent damage to the renal function due to uncontrolled diabetes and due to formation of gas and parenchymal distortion, and such kidney may need delayed nephrectomy after stabilization by drainage either internal or external. So we will follow such type of patient with ultrasound, CBC, serum creatinine, urine routine whenever it is required as per the clinical findings, and plus minus CT scan and DTPA scan. If it is parenchyma is totally or majority parenchyma get distorted in pre-treatment CT scan.
So I will just give a small suggestion to all the students.
Yes, sir.
That if at any given time, if you think that this kidney is giving trouble, you understand? Because I have come across a patient who has otherwise improved, but in between they keep on getting some urinary tract infection. They will get pyelonephritis type of symptoms, like, they keep on, and then pus cells, it reduces. It becomes 10 to 12. Again, slowly it will rise. It will become 100, 150. Patient may come with little fever, So to save the opposite kidney, you might have to take a bold step. Provided DTPA scan is showing, yes, this kidney is not functioning well. And I have seen that after doing that, instead of deterioration, the creatinine may decrease because the septic that focus has gone away. So at one stage, you cannot be dogmatic that no, because it's diabetic and I want to save this kidney. If needed, be bold and go ahead and do the nephrectomy. But as far as possible, try to save this kidney.
Okay.
Anything else? Maheshwari ji, anything you want to
Yes, sir.
ask
I
about
think that's
emphysematous
well covered.
pyelonephritis? Anything or your suggestions?
No, I
Because
think it's well covered.
one thing is their theory. Second part is what they should answer in exam, and the third is now they have passed their theory exam, and I'm sure they will all clear their practical exams also. And within 1 month, they are going to be consultant. So they will be taking decisions on their own,
True.
So through our clinics, basically we are teaching them how to be a good consultant. So I want you to give them some good hints, not only about this, even after in their practice, how to go about. If you can just give say 2-3 lines to them, some pearls of advice.
नहीं सर, वक्त आने पर बिल्कुल दे देंगे, अभी तो एग्जाम के हिसाब से पढ़ाई करने दीजिए.
Okay, okay.
But yes, means I was really not ready for this type of question from Dr. Gaurang Shah. We will discuss this when time comes.
Okay, okay. I think when we finish our clinic lecture, I think we should keep 10 minutes, to give them some good advice as a how to
Surely, sir.
be
I
a
think
good
in the
consultant.
West Zone we had a very good session on this about how to make the treatment patient centric.
Okay.
We had a 1 hour symposium on that. And in that we had covered all small things, including small practice tips. Yes, we can discuss that at some time, sir.
Fine, fine.
I
Okay.
think, sir, Maheshwari, sir, your take-home message today should be just do what you're doing routinely. I
Absolutely.
think that is what, like putting the
So,
stent or
yes, I
not talk about
100%
some
agree
PCM.
that don't try to give some different answer in exam.
Correct, sir.
Just
Agreed.
tell
What
them
they should
what
learn.
you
Yeah,
routinely do in your center. The
Yes,
moment
fine.
you try to give some different answer, you get stuck from both the sides because you have not experienced that different aspect of treatment. You may have difficulty in giving the correct answers for follow-up, and you have left behind what you routinely do. So दोनों तरफ से आपको मार पड़ जाएगी. You will have
Yes.
difficulty explaining your treatment option. So even if it is not theoretically 100% right, you can still get away saying कि हमारे यहाँ ऐसा करते हैं.
But usually, sir, in any center, 99% the routine practice is acceptable to everybody.
Absolutely, absolutely.
तो ऐसा
Absolutely.
कोई रॉन्ग होने का चांस बहुत कम है.
बहुत कम है, बहुत कम है.
और रहा भी तो तुम्हारा टीचर कर रहा है तो सामने वाला चुपचाप सुन लेता है, वो एग्जाम में तो एटलीस्ट कुछ बोलेगा नहीं.
Surely.
Yeah.
You-
So
you
Paras,
should
have
not-
you got
you
that
should not
video of putting a DJ stand?
No, sir. No, sir.
No. Okay, okay,
Quarter wala, sir.
okay. Fine.
So
So I
what we
think
meant is today that, like you said, okay, instead of PCN, you can stay DJ standing because literature supports it, and that's what we are routinely doing. But don't
Yes, sir.
go in the exam and say, okay, there was a patient in casualty multiple times. Somebody has tried to put catheter, it is not going, bleeding for urethra, and then you have taken the patient to OT and done cystoscopy. Don't say that in exam. Say you put
Yes.
suprapubic, and then you will do a ASU when she settles down, and then you will plan it.
Yes.
So you have to understand the situation, what we mean. Okay.
Yes, sir.
It's not necessary to keep on saying PCN. You may be justified by saying DJ stenting in today's case, but what should be followed as a protocol has to be followed as a protocol. For example, you have a patient bleeding per urethra, then you do the ASU, work him up, settle him down, do a suprapubic, then take it to the OT.
Yes.
So take it as case by case and just relax and do. You guys are well read here. We have done so many clinics and classes. That should be the take-home message.
Yes. Thank you, sir.
Okay. Good night,
Okay.
Gaurang sir,
Good night.
Gite sir, Pankaj
Yeah.
sir.
I think next time now we have got we had done one seminar in West Zone about
Yes.
multiple renal this thing malignancies, that is T1A, T1B, and T2. So I am thinking that the same thing we'll do next time. So I'll just let you know, all of you. But I want minimum of 4 to 5 volunteers. So just give me names and I will telephone them. Okay?
Prashant, today first time is presenting, sir. Next time Prashant will only be there. Tejas
No, but
and,
I don't want Ojas and I don't want Abhishek. I
yeah,
want
they are
some other people.
only they two are talking. Next time Prashant, sir. Prashant.
Prashant and another
sir.
4. Okay?
Yes, sir.
Okay.
Yes, sir.
Okay. Fine.
Yes, sir.
Good night.
Good night,
Good
everyone.
Good night, sir.
Good night, sir. Good night,
Thank you,
teachers.
sir.
Thank you, Pankaj.
Thank you,
Thank you
teacher.
very much.
Right, sir.
Thank you,
Bye.
sir.
Thank you.
Yeah.